can hormones cause cancer? Yes, your endogenous hormones can cause cancer as well. Cancer starts well before you ever diagnose it. It's years in the making, right? It isn't like you put somebody on hormones. It's years in the making. So a lot of where cancer comes from when you look at hormones is how our bodies metabolize those hormones, right? So if I have perfect metabolism and I eat perfectly healthy and everything is going down the right pathways, that's great. But you're right. There are some genetic predispositions that my hormones might be metabolized differently. If I'm fat, my hormones are metabolized differently. If I eat crappy food, my hormones are metabolized differently.
Welcome to Old Guy Talks to Me, a podcast dedicated to helping guys create kick-ass lives for themselves and those that they love. Ladies, if you want to know what your guy is thinking, this podcast is for women too. Each week, a special guest helps you create that life you've imagined. We talk anti-aging medicine, personal growth, relationships and hot sex. Yeah, you hear me, getting laid more frequently, other guy vices, and topics that many don't want to talk about but need to. Just because you're getting older doesn't mean you have to be old. Don't want to miss anything? Be sure to subscribe, share, rate, and review this podcast. And be sure to go to www.thestandard.academy/magazine and grab a free copy of our new digital magazine, The Standard Academy, where we talk about erogenous zones, growing hair back, and other things that will help you create that kick-ass life. Now get ready to listen up and share with friends.
This is Orest, the official old guy at oldguytalkstome.com, a podcast dedicated to helping older guys, helping all guys, not older guys, just all guys create kick-ass lives for themselves and, those that they love. Because, if you just take care of yourself, that's something, we call that something else, but we're not going to use that word today. I have used that word on my program, but we all know what we're talking about. And today I have Dr. Elizabeth Yurth, MD. And I was just looking at her bio here, and she has, after MD, she has literally 22. I counted them, 22 letters. That's 22. I counted them individually. I had to know. There were a lot of them, and I'm not sure what they all mean. These are all things that she's done to elevate herself beyond the mere mortal status of being a MD. But she's a medical director of the Boulder Longevity Institute, and which she co-founded in 2006, and it specializes in advanced research-based longevity medicine, including treatments such as bioidentical hormone replacement therapy, regenerative orthopedic procedures, and regenerative peptide therapy. And she obtained her medical degree from the University of Spoiled Children, which is known as University of Southern California, Keck School of Medicine, and completed her residency at the University of California, Irvine. All great places to be. We had nice, we used to live in Newport Beach for a short while. And she's been practicing for 25 years as an orthopedist specializing in sports medicine and spine medicine. And there's a long bio here. Which I'm not going to.
We don't waste all our time on that, right?
But she's an active athlete herself and has consulted with numerous sports teams, including the San Francisco 49ers and the Stanford University women's basketball and soccer teams, which are really actually very, very good teams. Stanford's always up in the top 10 on the women's rankings, and they just
not that anybody pays much attention to those women's basketball, but
I do. Just because my youngest daughter played basketball through high school, and she's resides in Boulder, Colorado, with her husband and 5 children. Thanks for being on the program, Betsy.
Thank you for having me, Orest. I appreciate it.
All right.
And I'm thrilled to be able to talk about this topic we're going to talk about, because it's.
Oh, I am too, because there are so many myths surrounding women's hormone therapy. I don't know if there's more myths around women's hormone therapy or men's hormone therapy, especially testosterone, because I still have as I said, I've said this many times on my podcast. I've been on testosterone optimization for over 25 years. Way before it became popular. And when I started doing it, my primary care physician said, well, I was going to get prostate cancer. I was going to get heart disease. My balls were going to fall off, and all sorts of other things.
Yeah, terrifying people, right? Yeah.
Yeah. All sorts of things which did not happen. And now I am actually, I have a kind of a different relationship with most of my physicians, because like he's a skinny guy by nature, and he's got slumping shoulders from losing muscle mass as he's getting into his 50s.
So, don't you see that just sort of stooped over, looking.
Yeah. And I have no qualms about telling him about that. And his nurse practitioner looked at me like, who the hell is this guy talking to my doctor like that?
Well, and both women's and men's hormones, unfortunately, it suffered from research that was carried out many, many years ago and was largely flawed. And then trying to reverse those theories. In testosterone, for instance, 2019, the urology review came out and said, listen, we actually have seen a 33% reduction in prostate cancer incidence in men who take testosterone. So they actually, it has a protective effect, and yet we still consider it the cancer causing thing in men. It's not at all. In fact, it has a protective effect. So these myths keep getting propagated, as oftentimes happens in lots of fields, but medicine particularly, I think.
Yeah, it's interesting that I wasn't aware of that study from the urologists, because they were really slow to get on board on this.
Well, they still don't. This is out of their journals, but they still don't follow it, right? I mean, it's
yeah. So and there were people. There's two actually consensus papers from the Mayo Clinic, which everybody like figures that's like going to church and reading the gospel, and they talk about actually the myths about testosterone, and they actually do a very nice job of outlining in both of them. And actually, whenever everyone tells me about testosterone, I just, okay, you want to go ahead and argue with the Mayo Clinic, okay? So, but let's talk about women's hormone therapy, because guys are like guys that are listening to my podcast, and women also that listen to my podcast too. They're at that age, they're starting to go into menopause, or maybe they're in menopause, or maybe they're postmenopausal. And there's all sorts of scares about all sorts of things in terms of hormone replacement. And so let's talk a little bit about where did this insanity start?
So really, it all started in actually 2002. So what is that now? 21 years ago. 2002, the Women's Health Initiative study came out, and that was a huge NIH-sponsored multi-outcome trial. So they took women and they put them on low-fat diets, calcium vitamin supplementation, and then an estrogen progestin therapy. So basically, it was Premarin. It was a conjugated equine estrogen. So it was a horse estrogen along with Premarin, which is not progesterone. So progestins are not progesterone, something we'll have to get into. Completely different hormones with completely different effects. So they put them on that because that was the standard of care. And most of these women were in the 50 to 70 age group. 50% of them were obese. So they actually took people preferentially who were less healthy. So 50% were obese, 50% were smokers. Their goal was to take a general population sampling, and at that time, supposedly 50%, it's probably more now, of people are obese, but certainly not 50% of people smokers. So we know they also had other risk factors as well, right? So we're starting out with a group that has high risk factors, and then we put them on a protocol of a low-fat diet, some vitamin, some calcium supplementation, and estrogen and progestin. And then they start the study, and lo and behold, into the study, they're like, oh my God, things are looking so bad that we are halting the estrogen progestin line and telling every woman, and women were, much more women were on hormones back then. It was sort of standard of care. And, women weren't feeling well at menopause. Their primary care docs were like, well, let's start on some hormones. They started on Premarin. And so lots of women were on these hormones. When the study came out, they were like, oh my God, we're halting the study because this is so bad. We are seeing such a difference in cancer risks. And so what they said is that the breast cancer stroke, blood clots were all were increasing with this therapy. And so they actually halted that portion, that arm of the study, and said, you guys need to pull all of your women off hormones. Now, they did ignore other parts of the study because indeed the study actually showed that there were also some very significant benefits going on from the hormones, such as colon cancer risks were going down, fracture risks were way down. So they halted it based on this breast cancer kind of stroke risk. And it reduced the use of hormones at that point by almost 80%. So women just were pulled off hormones by the primary care doctors. Primary care doctors said, oh my God, this is horrible. Women should not be on hormones. This is really bad. So it decreased substantially. And, and after that, some further studies started coming out. Unfortunately, the further studies pretty much got ignored. So, so women all got pulled off their hormones, and they started to sort of, look at what happened afterwards. And since then, for instance, 2003, in Norway and Sweden, so everybody kind of got pulled into this women's health initiative stuff. So Norway and Sweden, they followed people at the 5-year mark and said, wow, actually, we're seeing no change in breast cancer. And then by 2008, when all these women had been pulled off these hormones, and this was a large study that was being carried out and these women followed, they actually started to see all these women's breast cancer rates increasing dramatically who had been pulled off the hormones. So they actually saw worsening.
I just I want you to state that again. Getting off hormones, women's hormones, increase the rate of breast cancer.
Yeah. So so Norway and Sweden had some very big databases they were following of these women too. So with the use of the hormone therapy dropped 70% in this group that was being followed, and followed them at the 5-year mark. So they started 2003. By the 5-year mark, they said, oh, actually, we're seeing a increase in these women who were pulled off their hormones. So they started seeing further breast cancer rate increases. So they started to see it sort of stable off. So it wasn't like after they pulled everybody off their hormones, the rate started to decline, which you would have thought would have happened if that was causative. But then by 2008, they actually started to see them increase. And so they basically said, they published a study saying it looks like this Women's Health Initiative data was false, was not correct, and we need to relook at it further. Okay. So then 2017, the journal Climateric, which is a big menopause journal that's all the obstetric gynecology field utilizes, they basically start looking at other things as well, such as coronary artery disease. And they found that all these women started having increases in coronary artery disease as well. In fact, things actually got so, there was multiple studies that kind of came out after that, to the point where I think it was 2017. So now about, 5-6 years ago, the U.S. Preventive Task Force. This is your conventional medicine U.S. Preventive Services Task Force, the USPSTF, basically put a statement out, and I'm going to read it because it actually is so dramatic. They basically put a statement out that said that in May, statements that read, in May 2017, perpetuate a major disconnect between the primary population affected, women within roughly 10 years of menopause, and the data cited. As currently drafted, the recommendations reiterate that that we're causing egregious harm to women, to public health, by having pulled all these women off hormones. And the data that was presented was both misinterpreted and misstated, particularly in relation to coronary heart disease and breast cancer risk. And then we need to relook at this data and start taking another objective view of how we're treating women. So the USPSTF made a statement saying this data was false, it was misleading, and it created a lot of harm. And yet today, the #1 study that's still quoted by your doctor who won't give you hormones is the Women's Health Initiative study.
That is amazing, because that's a pretty definitive statement. And Yeah.
And this is a very traditional organization, right? They're not,
and they don't normally make these kind of definitive statements. They usually kind of hedge then they kind of ended up and at the end, and more studies are needed, or something like that. But it's very rare for a scientific journal to make that kind of
this data was misinterpreted, misstated, misleading, particularly in regards to coronary heart disease and breast cancer risk. That's a pretty remarkable statement to make.
Yeah. So this is, go ahead. I'm sorry.
So I think, the biggest problem in medicine, is, and you've seen this, is that we get on our belief systems, and it's very, very hard to change, particularly when you're dealing with, well, if I do nothing, at least I'm not liable, right? So if I do nothing, even if it's not the wrong thing, even if that's the maybe not the best thing for my patients, then at least I'm not going to be held liable for what I do. So we're kind of driven by fear a little bit in medicine. And unfortunately, that's at the detriment of our patients.
Do you need accountability? Are you looking to change the course of your life but have failed to keep on track? Too often we take in information and fail to act. Do you need an accountability program to stay the course? Then go to www.thestandard.academy and find out about my accountability program that goes with my course that helps you find out what you want, why you want it, and how to get it. The accountability program keeps you on track to get results.
Yeah, I understand that also some physicians are recommending some tests for cancer risk before hormone therapy. What's your thought on that?
Well, so I would say, okay, well, can hormones cause cancer? Yes, your endogenous hormones can cause cancer as well. Cancer starts well before you ever diagnose it. It's years in the making, right? It isn't like you can study hormones. It's years in the making. So a lot of where cancer comes from when you look at hormones, it's how our bodies metabolize those hormones, right? So if I have perfect metabolism and I eat perfectly healthy and everything is going down the right pathways, that's great. But you're right, there are some genetic predispositions that my hormones might be metabolized differently. If I'm fat, my hormones are metabolized differently. If I eat crappy food, my hormones are metabolized differently. So when we look at estrogen, for instance, and this is whether I give you estrogen or whether you're a 20-year-old female who makes their own estrogen, your estrogen can go down 3 different pathways. So once it's metabolized, it can go down 3 different pathways. One of those pathways is 2-hydroxyestrone. 2-hydroxyestrone is a protective estrogen for the most part, okay? Another pathway is 16-hydroxyestrone, which is kind of an in-between. It has some goods and bads. And then there's 4-hydroxyestrone. 4-hydroxyestrone is a bad player. And this is true in men for prostate as well. So does testosterone cause cancer? No. But as men get older, they can metabolize testosterone into 4-hydroxyestrone. So, as men get older, they will do a lot more taking their testosterone and turning it into estrogens, especially if you're overweight or you're eating badly or you're not exercising. So if that testosterone there's an enzyme called aromatase, turns it into estrogen. If it's a good estrogen, actually there's some very protective benefits to that guy. But just like women, if that estrogen then goes down into a 4-hydroxyestrone, 4-hydroxyestrone is a bad player. And it actually becomes what's called a reactive quinone, meaning it can insert into your DNA and can damage DNA, cause tremendous oxidative stress, and it is a precursor to causing changes in cells that can cause cancer. So 4-hydroxyestrone levels are very linked to men prostate cancer and women breast and ovarian cancer. So if I put somebody on hormones, or if you're making your own hormones, doesn't matter, I should know how they're being metabolized. And I don't do genetic testing for that. What I do is I follow the metabolites, right? Because even your genetics mean very little. You could have genetics that are really not great, and yet you eat perfectly, and you're taking, you're eating lots of cruciferous vegetables that are blocking these pathways, and you're not on other medications that are competing for these pathways, and you're exercising. Those genetics mean very little, right? That's your epigenome. So basically, the better way to follow this is to look at how these hormones are being metabolized, which you can very easily do with urine testing. So if I give you something and I measure what you're peeing out, that tells me what you did with that hormone.
Okay, that's interesting. And so a family, so this again, people talk about, family history of breast cancer. That's not a contraindication to getting hormone therapy, is it?
It's really not. So you have like the BRCA gene, right? So those people who have, again, we're not, remember, it does not, the hormones are not causing cancer. So you can't in one arm say, oh, well, you've got the BRCA gene, you're at a high risk for cancer. And the other arm say, well, but hormones don't cause cancer. So why do I care? So those are not contraindications. Now, what the BRCA gene can do is change how those hormones are being metabolized. So those people you need to follow more closely and do things to make sure that they're metabolizing down the correct pathways. So what we'll do is we'll use things like 3-indole carbinol or diindole methane, which block the 4-hydroxyestrone. We'll improve detoxification pathways using things that make your liver work better to get rid of the bad hormones, right? So in those people are going to be more cautious to make sure that they're metabolizing down the right pathways, because their genetic predisposition makes the likelihood that they're metabolizing those hormones differently a little higher. But I can protect that person if I know what's happening and I correct it, and then I drive the hormones down the correct pathways.
Okay. All right. And so what, you mentioned something about liver protecting process. What's that involve?
So remember, our liver is one of our big detoxification organs, right? So, and that's true of all the, even if you're not taking estrogens, I will tell you, you are getting exposed to estrogens. There are estrogens all over our environment. Even if you're pristine about not eating anything out of plastic bottles with BPAs, there's estrogens in your food, there's estrogens in your water. Even if you eat the best filtered water, you are likely getting estrogens. So remember, you are getting exposed to estrogens. One of our goals is for our liver to be able to detox those things that we're exposed to, be it estrogens or be it Roundup, all the bad shit we're exposed, the bad stuff we're exposed to. So basically, one of those pathways is through the liver. And there's kind of 3 different sort of detoxification pathways that are most important in our body. One is methylation. One is basically using a glutathione detox, and one is what we call glucuronidation. So we can accelerate all of those pathways. For instance, everybody, as they're getting older, and I would say young people too, need to support glutathione. Glutathione is one of our detoxification pathways that we utilize to get rid of all this chemicals we're exposed to. So simple way to increase glutathione is to take a little N-acetylcysteine. Take N-acetylcysteine, about 1.2 grams a day. That should probably be a pretty mainstay for those of us who are living in polluted environments and things like that. Or if you drink alcohol. If you drink alcohol, you need your liver supported with something like N-acetylcysteine, because you have to be able to detox that alcohol or it's doing damage. It's doing damage anyway. But so NAC, N-acetylcysteine, increases glutathione, right? And then you can do things that help your body to methylate. That's another detoxification pathway, such as taking B vitamins, some methyl B12, methylfolate, some of the B vitamins. So those are simple approaches that are going to turn on your liver's ability to get rid of all these chemicals you're exposed to, both environmentally, but ones you make on your own, right? So if you're doing those things as a male, you can actually help to prevent the buildup of these bad estrogens that are going to be linked to prostate cancers.
Sure. Okay. So, so this liver detoxification seems like a very, very important thing in terms of, especially if you have bad habits.
Especially if you have bad habits, right? Yeah.
So that
unfortunately, alcohol is pretty. Use of alcohol in our society is pretty robust, and it's our social network, and people, I don't think there's really a safe amount of alcohol, but people are going to drink. So try and do your best to protect what you can by utilizing things that help you to detoxify that alcohol.
Yeah. So if a woman is coming to you for, in your practice, is coming to you for hormone replacement therapy, what's the process that you go through, and how long does it take to get someone tuned in? It seems like, guys, it seems like it's a lot easier to to tune in to testosterone. It's versus I've heard that it takes a little bit longer to kind of figure out what the right cocktail of medicines or hormones is for a woman.
Yeah, I think that that is true. You know, and partly because we're dealing in women with 3 different hormones, right? Men, and that's true with men too. I mean, men need estrogen and they need progesterone and they need testosterone. That gets neglected in men as well. Nobody looks at progesterone levels in men, and they're really critically important. You need to have progesterone for protecting the prostate, for protecting the brain, for protecting joints. And a lot of times it doesn't get looked at in men. Lots of men need progesterone. So for instance, in men who are on testosterone, if their progesterone levels are low, they're more likely to get prostatic hypertrophy, prostatic cancers. So progesterone is very, very protective to men. Helps with their sleep, helps with their brain function. So don't forget that all of us have the same 3 hormones, men and women, in different ratios, right? So in everybody, they all need to be looked at. In men, 17 beta estradiol is a longevity agent. It's men who have a little bit of higher levels of estradiol actually have better longevity. They have better brain function. So even estrogen, those guys who are blocking all their estrogens, that's not a good thing either. You need estrogens. You need some degree of estrogen. So all 3 of those hormones are important in everybody. I would argue in women, one of the problems is our ratios are changing. So they need to be balanced. Estrogen has to be very balanced to progesterone. Testosterone has to be very balanced, and they're changing kind of constantly as we age. So, once women's hormones sort of are kaput completely, it becomes easier, but that doesn't happen until very late in life. We are producing hormones but the ratios are declining. The first thing that happens at very young ages, 20s, our progesterone levels really start dropping. So for a long period of time, you start seeing this estrogen dominance occur. And when women are estrogen dominant, this is when the men are like, oh my God, I can't live with her anymore, right? Half the time it's the men coming to me who are seeing me for something else. Like, can you please see my wife? I really can't stand it anymore. Because when women become estrogen dominant, it's, estrogen, think of it as sort of that everything men think about women, right? Progesterone balances that out. So as you start to get high levels of estrogen and low levels of progesterone, you start to get mean and bitchy and can't sleep and your joints hurt and everything, and everybody around you is suffering as much as you are. So that balance over time. So for a while, maybe all I need to do is give them some progesterone. That's all they need, right? Eventually their estrogen levels are going to start dropping and I'll have to replace those. So that's one of the reasons it's difficult. It's getting that symphony playing in order. So that's probably one of the most difficult things. And this is true with men and testosterone too. You have to rely on how people feel. And some women feel great with a little bit of estrogen, and some people need a whole lot more estrogen, and some people need a whole lot more testosterone. And so it's a lot of listening to your patient's symptoms too. And I think that doesn't get done enough. People get put on these standard doses. This is the dose we give you, and they're like, well, I don't feel any better, and it probably was not the right dose for that person. So you've always to balance this ratio of progesterone to estrogen. Women have to have testosterone. Testosterone drops early. Remember, any of your women on birth control pills block testosterone. So women on birth control pills are going to have very low testosterone levels. It gets bound. Birth control pills raise something called sex hormone binding globulin. It binds out testosterone. So all these young women on birth control pills have very low levels of testosterone. They have much more trouble muscle building. So that needs to be looked at. So women need to have testosterone that starts dropping at an early age as well. And so that gets ignored in women as well. So I think that's one of the problems, is that getting that balance there, getting all those pieces together. So when a woman first comes to see us, first thing I do is go through all this, because the first thing I'm going to do is, well, my doctor said I really shouldn't do hormones because they cause cancer. And, and so we have to debunk that myth and show them the data. We also have to show them that even the Women's Health Initiative study, as evil as it was, showed that those women had much lower risk of fractures, lower risk of cardiovascular disease. So basically it was not that everything was bad. And really the only thing that was bad was the progestins. So when they took progestins out of the mix, they just looked at estradiol, they didn't see any of those risks. The progestins were very bad. Mm-hmm. So remember, progestin comes from a different source. It's not anything like the progesterone that we make. It doesn't sit in our progesterone receptors. So it does nothing to protect us. The only reason it was utilized was because when you put something in estrogen, it kept the endometrial lining from getting too thick. So it balanced the endometrial lining, but otherwise it did nothing to help any of the other things that progesterone does. So that was the big things. You have to start looking at estrogen, just like the ones you make, the estradiol you make, and progesterone that's bioidentical to the hormones that you make. So testosterone is always bioidentical. Now, estrogen, people always say, well, you have to have it compounded. Estradiol is estradiol. It doesn't matter if you buy it from a pharmacy. If you get it from a compounding pharmacy, it is estradiol. So that's a little bit of a myth. Estradiol is estradiol. Progestins are not progesterone. So first of all, I debunk that myth. I talk about you've got to have hormones for protecting for bones. Absolutely have to. I come from an orthopedic background. You know what is really likely to kill you is falling down and breaking your hip. So if you fall and break your hip and you're over the age of 60, you have a 10-fold risk of dying in the next 10 years.
Thank you for joining Dr. Orest and his incredible guest. Like what you heard and learned? Then be sure to do 3 things. 1, subscribe so you don't miss the next episode. 2, share this with someone who may need to hear it. 3, leave a review and rate this podcast. Opt in at www.thestandard.academy/magazine and get our free digital magazine with savings, articles, and deeper dives into cool controversy. Be the guy who takes action. Without action, you're not going to get the results you want. Thank you again, and make it a great day.